Good morning, good afternoon, good evening, dear speakers, dear moderators, dear members of the expert panel, dear attendees. My name is Sylvain Gaillard. I'm the head of corporate medical marketing of Sigvaris Group. And as such, it's a great pleasure for me to welcome you in the name of Sigvaris Group to this second MOH, the Medical Online Hub webinar discussing today two international consensus papers on indications and contraindications of compression. It's especially great pleasure for me that nearly the entire group of authors of the two consensus papers is present today, either as moderators, experts, panelists, or speakers of the MOH webinar. I would especially also like to thank Professor Hugo Patsch and Professor Eberhard Rabe for their tremendous works as chairs of the consensus panels that made it possible to publish the two consensus papers in such a short time, despite the large group of international authors involved. I would like to thank you for your interest in this MOH event. I wish you a great MOH webinar with very interesting high-class presentations and discussions. And with this, I would like to hand over to Professor Giovanni Mosti for the introductions of the moderators, speakers, and topics. Giovanni, the scene is yours.
Thank you, Sylvain Gaillard, and thank you, Sigvaris Group, for inviting me to participate in this great webinar on international consensus on indication and contraindication of compression therapy. Obviously, from my point of view, as you know, I'm a compression maniac. I wish that we will find in this webinar more and more indications and less contraindications. My task today is very easy because I have to introduce very famous panelists. They certainly don't need any presentation. So I hope everybody will forgive me if I will tell you something you know already perfectly. Before starting, obviously, I would like to welcome all the participants and to thank you to stay with us today, and a special thank, I would say, and a special welcome to all the people, to all the participants who are not in a comfortable time, because we know that for some of them it's very early in the morning and for some of them it's very late in the evening. Having said that, I would like to introduce the first speaker, and the first speaker is Professor Rabe. As I told already, Eberhard doesn't need any presentation, but anyway, this is my task. So I will tell you that he has been the responsible for phlebological department in the Department of Dermatology at the University of Bonn. He's now Professor Emeritus. He's retired 1 year ago, and he practiced privately in Bonn. As you perfectly know, he has been the president of the German Society of Phlebology for many years. He was the president of IUP from 2007 to 2011. And is now president of the European College of Phlebology. He's very much involved in education and in scientific field. And we thank Eberhard so much for chairing the groups, both in indication and contraindication for compression. And today he will speak with us about indication in chronic venous disease. Eberhard, please.
Giovanni, thank you very much. I'm not sure if you see my screen. Yes, now. Thank you very much. Thank you very much for this nice introduction, of course. My task is not on the contraindications today, but on the indications for medical compression stockings only in chronic venous diseases. The consensus you made was also about acute venous diseases, but this is only on chronic. And these is my conflicts of interest. And the background is that in 2008, Hugo Patsch and the ICC published a consensus statement on the use of compression therapy in venous and lymphatic diseases. But at that time, there were several clinical questions, however, where there was a gap in the available evidence. So the recommendations were just not well based on the literature because it was not available. So our task now was to provide an update of these recommendations on the the evidence we have today and on the papers which have been published since 2007. And what we did was a literature search from 2007 to July 2015, and there were quite many publications on compression therapy, but at the end we found 51 new evidence-based publications on which we could base our recommendations and our consensus. This was the result. Our consensus on indications for medical compression stockings in venous and lymphatic disorders was published in 2018 in Phlebology. And I again want to thank all the authors and all the members of the group, for the great work they did and for the support of the Sigvaris company, of course, also. Without them, that would not have been possible. So the first issue was symptoms, quality of life, and edema, because these are the reasons why most of our patients put on their compression stockings. It's not so much ulcer healing or things like that, but for most of our patients, symptoms are key. And now we have 5 studies which have reported a relief of aching, pain, leg cramps, and restlessness. So we recommend the use of compression stockings to alleviate venous symptoms in chronic venous disease, and also to improve quality of life and venous severity with 3 studies which have reported that. Aside of the symptoms, the use of MCS to prevent leg swelling in healthy individuals, not only in venous insufficiency patients, is also an indication. And there was also an RCT from Australia showing that to prevent flight edema, you can wear compression stockings. We also recommend the use of MCS to reduce leg swelling, not only to prevent leg swelling, in occupational leg swelling and also in chronic venous disease. And there are 3 studies which have reported this issue. If you look to this nice meta-analysis by Amsler and Blattler, you can see that if you put the studies together, you can see for subjective symptoms comparing low compression in these cases, 10 to 20 millimeters Hg compared to placebo or low pressure below 6 millimeter Hg compression, there is significantly a favor for compression to improve subjective symptoms in those patients. And the same is true for edema. There are 3 studies, at least 2 of them have a significant improvement of edema and edema reduction also with low compression stockings. And that means that there is these studies favor compression against placebo or no compression. Hugo Parch already in 2004 could demonstrate that evening edema can be reduced by wearing compression stockings, even with a very low compression pressure, 10 to 50 millimeters Hg, in a very similar way as 20 to 25 millimeters Hg stockings. So also at that time, we could show that low compression pressure is able to reduce evening edema. The literature is not so good for skin changes. There are not so many studies, although we regularly use compression stockings to improve skin changes like eczema in our patients and also inflammation in the legs. There is a paucity of evidence from RCTs. So this indication is just a 1C recommendation. However, for the use of compression stockings for the improvement of lipodermatosclerosis, there is at least 1 study by the Van Dongen group showing that it's possible to improve those skin changes, especially lipodermatosclerosis, by compression stockings. The best evidence we have for compression treatment is for ulcer patients. And the first is the recommendation to use compression stockings to reduce recurrence of venous leg ulcers. And there are 3 RCTs and also a Cochrane review showing in principle that there is a trend to lower rates of venous ulcer recurrence with higher compression, MCS, and compliance, however, was lower in high compression groups and has positive outcome also. However, if we use ulcer kits now for the treatment of ulcer healing or for ulcer healing. This is a new issue after 2008, because at that time we didn't have good studies on that. But now we have 5 RCTs which report an improvement in ulcer healing with the use of ulcer, especially 2-layer ulcer stockings. And this is now also a 1A recommendation. Interestingly, it's not only ulcer healing, but pain is an issue in ulcer patients. And there is also some evidence showing that the use of ulcer stocking and ulcer kits can reduce pain in patients with venous lung ulcers immediately after start of the treatment, even if the ulcers are not healed. So you can see in this Cochrane review from 2012 by O'Mara that at that time, the evidence for high compression stockings, or especially for 2-layer stockings, was not present in this way, but at least compression at that time was clear to increase ulcer healing rates compared with no compression. In the meantime, for instance, we have the study of Ashby in Lancet from 2014, who compared 4-layer bandages and 2-layer ulcer MCS ulcer kits. And he could show that the healing rate of 70% was almost identical between these 2 treatment groups. And for the 2-layer compression ulcer kit group, there was a benefit also for costs. For prevention of recurrence, it's interesting to see that there is a study by Clark Maloney who could show that even if we compare class 1 and class 2 stockings, there was no significant difference between recurrence prevention, but only if you, in the group which did not adhere to compressions treatment, 7 of the 11 had a very high rate of very early recurrence of venous ulcers. To put that together, based on the current literature, the healing rates of venous leg ulcers are comparable between medical compression stockings, especially for ulcer kits, and compression bandages. However, Giovanni, you are right, saying that reasons for compression may not be chosen, for instance, in circumferential ulcers, untypical locations as in the foot, high amount of exudate or very gross edema, and then, of course, we still choose compression bandages. Post-venous interventions is another issue. We have no data if we can prevent the progression or the, let's say, the recurrence of varicose veins after treatment by wearing compression stockings from RCTs. We need those RCTs to be done. So we could not do a recommendation on this point. However, for the initial phase of post-treatment varicose veins with interventions, there is some evidence which reduce with reduction of side effects in the first week. So this is a 1B recommendations to use compression stockings in the early phase after venous interventions. And we also recommend to use additional eccentric compression to enhance the pressure below the bandages or the stockings. There is limited evidence that we should go on with compression after the first phase, also in the international guidelines. However, we would recommend to going on with compression in those people, in those patients who have an ongoing of CVI symptoms or signs, and they need to have compression even after the interventions. For the use of MCS after liquid sclerotherapy, there is an evidence from one study, so we recommended that. This is an enhanced eccentric compression in the study of Marcia Lully, and she could show a reduction of pain in the first 7 days on a significant basis. And also this nice study from the Morans group, which is to be published now. We can see in the first 7 days, there's a reduction of pain on a very low level in a 10-point scale. However, this is a low invasive intervention with laser treatment of a great venous vein without side branch treatment, and with a 23 to 32 millimeter HG stocking for 7 or 28 days. versus no stocking. And you can see there is a significant difference, but on a very low level. The last recommendation I would show you is post-thrombotic syndrome. It's not on treatment of deep venous thrombosis. This is another issue. But there was some discussion if there is a benefit for reduction of post-thrombotic syndrome, especially from the SOC study, when compression started only 2 weeks after the diagnosis, and when even only 3 days of compression per week was accepted as a good compliance. And in this study, there was no benefit for prevention of post-thrombotic syndrome. However, now we have new data from immediate compression. I will show you a little bit later. And so we could recommend the use of MCS as early as possible after diagnosis of DVT immediately in order to prevent post-thrombotic syndrome. And then, of course, we use compression stockings for the treatment of symptomatic post-thrombotic syndrome, and there is evidence for that too. This is a nice study by Amin from Arena ten Cate Hoek group in the Netherlands, showing that comparing no immediate compression with immediate compression after 3 months, you could see that even only after 3 months, in the group with immediate compression, there were significantly less objective Villalta parameters, so were significantly less skin induration, less hyperpigmentation, less venectasia, less pain on calf compression in this early compression group compared to the group where the compression started later. So in conclusion, the new studies published since 2008 consensus, ICC consensus, document good evidence for chronic compression treatment in chronic venous disorders. Based on the current evidence, we have 14 recommendations for chronic venous diseases and 2 for prevention of post-thrombotic syndrome, which are improvement of venous symptoms, which is, in my opinion, the most important, because this is the most important reason to wear compression stockings in our patients. It's also prevention and improvement of venous edema, the improvement of skin changes, improvement of venous leg ulcer healing and recurrence, and the improvement of early side effects after venous interventions. And of course, not to forget also the prevention and the improvement of post-thrombotic syndrome. So the high value of applying compression stockings in the treatment of chronic venous disease is thus supported by the current evidence base. Thank you very much for listening to my talk.
Thank you very much, Eberhard, for this excellent presentation. I know that at this time we should have a poll from the organizers. So if we can see the poll, this is the poll. You need to choose the response and submit. And while you do this, I would also like to inform you that pressing at the question and answer button at the bottom of the screen, you can have questions and you will have answers. Eberhard, while we are waiting, I can tell you that we have already a question. First of all, the participant, thank you for the great talk. And then the question is, for how long we should apply post-thrombotic syndrome, the compression stocking? How long?
For the prevention of post-thrombotic syndrome, that would be the first point. It's interesting to see that from the same group, from the ten Cate group, they could show that it makes sense after 6 months after deep venous thrombosis to look to the patients clinically if they have post-thrombotic syndrome signs and symptoms, and then to decide to stop or to go on with compression treatment. If there are signs and symptoms in the legs, you should go on with compression stockings. If there are no signs and symptoms, it makes sense to stop compression treatment and to see what happens. If signs and symptoms develop. In the next 3 months, you start compression again. So this is the current evidence we have.
And the second question, should compression be at night also?
No, at least not in chronic venous diseases. For lymphatic diseases, now we have the discussion on night compression, especially night compression stockings. In my opinion, the compression pressure of a class 2 stockings, for instance, in elderly patients, for instance, may cause more problems than benefits, because in chronic venous diseases, in the standing and sitting position, we have the problem of the hemodynamic changes, but not in the night, not in the lying position. And so I would not recommend overnight compression stockings in chronic venous diseases in my patients, at least.
So no questions anymore. So I could go for the poll, and luckily just 2% of participants choose the first response, never. 26% they apply compression only in CVI patients, and 71% applies compression independently on CVI or not. I need to ask help to Sylvain now because Federer is not with us. So I'm asking if we have to introduce Joe Caprini and Nick Morrison at this time or later or when, I don't know.
I think it's the right time.
So I think that Joe Caprini has something to tell us about this topic, compression and post-thrombotic syndrome or deep vein thrombosis, if you like. Joe? We cannot hear you.
Unmute.
Unmute.
So I'm not sure what the question was. I thought I was on this panel to listen.
If you want to comment on compression in deep vein thrombosis and post-thrombotic syndrome.
Well, yes, I would absolutely like to do that. First of all, that was an excellent presentation, Eberhard, as usual. Very, 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 very good. And I think that, as you well pointed out now, excuse me, we're finally getting over the nightmare of the SOX trial. Not done properly, inadequate endpoints, and inappropriate conclusion that was just gobbled up by the Americans in their guidelines, influenced by the Canadians that don't like compression. And we all know in our practice, first of all, and most importantly, patients that develop deep vein thrombosis very frequently come with pain, swelling, and tenderness. That's how most of them get diagnosed. Giving them anticoagulants usually doesn't change that very much. And they come to see us as consultants to find out why the anticoagulants aren't working. And once we put them in appropriate compression stockings, then their symptoms are better. That's the first thing. The second thing is that I think that in patients that have deep vein thrombosis, it's very important to continue the compression therapy long-term. And we know that at least by 6 months, you can reevaluate the situation. There's two very interesting things here that Eberhard pointed out in his presentation, which I very much liked. The first, of course, is that the work by Hugo has shown, and also Giovanni, has shown that you don't need a lot of compression. And certainly, I think over time, after the acute symptoms are gone and so forth, even the lower compression stockings work very well. Next thing is we haven't paid enough attention to the reverse compression, or reverse gradient postulates and data that Giovanni has put out for us and shown us that reverse compression, not graduated, may even be better. All of that having been said, I would also like to comment on the business of this comparison between short stretch 4-layer compression, short stretch compression bandages and the usual little 2-layer ulcer kits, and even the 4-layer ulcer kits that they sell for ulcers. And Hugo put it best, and I think we all have to remember this. When you're using short stretch bandages, it's all in the hands of the applier. And it has to be properly applied, and you have to properly examine each patient. I know that one of the simple things we use is to squeeze the calf, and if it doesn't feel like a blown up football, you don't have enough compression on. But the other thing is that in our patients, we get them to wash their bandages, so they only ever get 2 sets. And so it's very cost effective, and I don't see that in any of the studies. So the other thing is we all have to learn more about Velcro and strap-like devices. And I would just like to point out, and I don't get anything for this, but monetarily or otherwise, but the latest Sigvaris product with bra hooks instead of Velcro is fantastic, because the bra hooks don't wear out. They're very, very easy to apply and take off. And people forget about the fact that when patients can't use stockings, won't use stockings, have trouble with donning and doffing issues, that the most appropriate thing is to go to one of these devices. And certainly if you can get the strap-like device with the bra hooks, it will last the longest and provide the best wear. So again, I'd like to thank you for allowing me to sort of run at the mouth for a few minutes.
Joe, it is always very nice to hear at you, but to stay on the correct time, I recommend everybody to have short questions and short answers and short comments. Thank you so much again. And the last 2 questions for Eberhard, and then we need to move. How soon do you start compression stocking to prevent post-thrombotic syndrome, and there is a specific pressure required?
I start immediately after diagnosis. So when I do my duplex ultrasound, even before applying anticoagulation, I start with compression. Let's say in the same time as I start anticoagulation, I start with compression. And the reason is that immediately when I do compression treatment in a painful leg with a deep venous thrombosis, the pain becomes less.
And there is a specific pressure required?
Usually when the leg is swollen a little bit more, we start with compression bandages. And the pressure I apply is, let's say, about 30 millimeters HG.
Okay, the very last.
For stocking, I would use a class 2 stocking, when there is less edema, or after 1 or 2 days, when edema was diminished, I would start with a class 2 stocking, 23 to 35 millimeters HG.
And the very last one, after CVI surgery, how long do we recommend patient to use medical compression stockings?
It's a very good question. So for the evidence we have now, if the patient after the operation has no longer any signs or symptoms of chronic venous disease, like swelling, feeling of swelling, pain, and so on, I would say it's 1 week is enough. But for many of our patients who have an operation, for instance, or a laser treatment, but they still have signs and symptoms of chronic venous insufficiency, even it's improved, I would go on with compression treatment in those patients.
Okay, thank you very much, Eberhard. And if Sylvain agrees, I would go on with the second speaker. And the second speaker is Professor Chris Latimer. He's working at the Joseph Luke Vascular Laboratory at Healing Hospital in London. He's an active participant in many scientific and educational events, and is author or co-author of really many scientific publications. Today, he will present about risk and contraindications, part 1. Chris, please.
Well, thank you very much, Giovanni, for the introduction. And it's always a privilege and pleasure to be giving a presentation for Sigvaris. And I thank Sylvain and Sigvaris for the opportunity to do this. The work's been published, but I'm not going to reiterate the publication from earlier this year, but rather to provide photographs, background behind the thinking, and some science. These are the 15 international personalities which contributed to the document. I just want to draw my attention, your attention to Professor Urbanek, who'll be talking after me, and also Tobias Hirsch, who'll be talking after Thomas. He's the current president of the Congress of the German Society of Phlebology in 2 or 3 weeks' time. The classification of compression, I think, is important because most of what I will be discussing and talking about is tension devices and not pure pressure devices, because we believe it is the tension that is the root of most of the complications and the law of Laplace. They can be divided into 2 elastic compression devices, which have sustained pressure and a rise in tissue pressure, and inelastic compression, which have rapid rises in tissue pressure. This is taken straight from the work, the risks and complications reported in the literature. The non-severe ones, skin irritation and discomfort and pain, seem to be the commonest. Allergies rare, so is forefoot edema, lymphedema, and bacterial and fungal infections. And the severe complications, and they all look a bit horrendous, really. Unfortunately, they are very rare, and that's defined as less than 1 in 10,000. But what we must remember is that what is reported may not reflect clinical practice, because many of the reports are anecdotal, they are selected, and there is an element of reporting and publication bias. So start off with general recommendation number 1. We recommend that every patient receiving compression therapy should be screened for conditions that increase the risk of complications, and every compression device should be checked for appropriate fit and application, and that the contraindications for compression treatment must be considered to limit the risk of the side effects. And these are listed at the end of the document, which I've got here, being severe peripheral arterial occlusive disease, epiphyseal arterial bypass, severe cardiac insufficiency, and also a confirmed allergy to the compression material. And to really think carefully if the patient has insensate skin, for example, after a stroke or diabetic neuropathy. Dermatoporosis, that could be considered a major contribution to an increase in risk. It may be as important as the ankle brachial pressure index. The dermatologists themselves are having a few issues with what to call it. Skin fragility syndrome, chronic cutaneous fragility syndrome, cutaneous insufficiency, age-related skin atrophy. But the point is the skin is paper thin, very thin. And if there's associated sun damage, it behaves like blotting paper, and it can be easily torn with the thumb and forefinger. Skin irritation, allergic skin reactions. Recommendation number 2. We recommend using adequate skin care to prevent skin irritation in patients with sensitive skin. This is self-evident, really. Recommendation 3. To prevent allergic skin reactions due to compression devices, we suggest avoiding potentially allergenic substances and dyes in compression material. Now, what exactly does this mean? I mean, I think this is something akin to wearing clothes, if you're allergic to your own clothes. It's very, very rare. But please consider this. The combination of a stocking with all its interstices, plus suitable creams and lotions which you might be allergic to or have hypersensitivity with, and this type of environment, if you don't wash the stocking, can collect all the antigens around the house, around the hospital, and it's something to just consider when people talk about allergies to compression stockings. This is a condition of compression-related dermatitis. You will struggle to find it in the literature. A diagnostic feature is the zone of demarcation. It's where the end of the lesion joins the adjacent fairly normal skin above or below. Every presentation these days does have a current COVID slide, and this one is no exception. This is PPE-related dermatitis, and it does occur on lots of frontline workers. When they take the equipment off, you can reveal various sores and patches. And the elements causal to this is often the moisture, the friction, the tension of the device, and of course, time. And to me, there are some similarities between this and the compression-related dermatitis. Recommendation number 4 concerns discomfort and pain. In patients with pain or discomfort below compression garments, we recommend checking the correct indication, pressure level, material fitting or bandage technique, as well as the correct donning and doffing. The area most susceptible to the discomfort is around the ankle region and sometimes to the foot. But for the correct indication, a reminder, I've produced this slide which is, summarizes the pathophysiology of chronic venous disease, which is a tussle between the vein wall tension, bad, versus our anti-gravitational mechanisms to cope with all of this. Where compression comes in, like the minion on the top right-hand corner, as you crank the handle, the minion gets more and more crushed and its tissue pressure will increase. And the same thing with a stocking or compression garment. And with a high tissue pressure, you reduce transmural pressure, reduce tension, and it's really a good thing. This is a condition, it's tension-induced skin stress. This is present in the consensus document. And these are these circumferential red lines and patches after the fitting of a well-applied bandage or a carefully measured stocking. And it can occur in healthy people, and it may represent the physical evidence of why compression devices can cause discomfort around this region in particular. This is one of my favorite slides. It's the sort of border zone between tension-induced skin stress leading on to a compression-related dermatitis. We can see our tension lines over here, the red patches, but they're redder and they've gone into the pathology really, and they are spilling over into the normal skin with slight areas of redness and patches themselves. Number 5, forefoot edema and lymphedema. In patients with or those developing forefoot or toe edema when wearing compression, we suggest considering forefoot and toe bandaging or forefoot and toe compression pieces in addition to leg compression with a foot piece. Now, this can sort of mean two things if you think about it carefully. Is it that the compression is preventing the drainage of the forefoot below, or does this reflect the remaining edema that the patient had before after effective compression has been applied? And a good clinical examination with a history of the patient and knowing the patient should be able to discriminate between these two. Bacterial and fungal infections. In patients with bacterial or fungal infection beneath the compression device, we could recommend considering treatment with topical antiseptics or antimicrobial medication. It seems self-evident. And in patients with systemic symptoms or cellulitis, we recommend that systemic treatment is given. So this is also, in a way, self-evident. And recommendation number 7, if the compression application or material is suspected to contribute to the infection, for example, lateral pressure over near the toes or interdigital maceration, we suggest a modification of the compression. This patient on the left has secondary lymphedema of the toes as a result of prolonged compression right up to the base of the toes. She's developed an ulcer at the base of her 5th toe. There's the typical creases, the squaring of the toes. Stemmer-Stein is strongly positive in this patient. And if you were to separate the toes, you'll see horrendous athlete's foot infection. So this is just an example of secondary lymphedema below the compression device. This patient on the right had a lot of, is not comfortable with stockings because they probably don't fit properly because of the pressure around here, and uses his snip technique to improve his compliance or concordance. And the lady at the bottom is perfectly healthy. And I don't think whatever you do with good skin stock, nice gaps between the toes, and whatever you do to her, I think it will be very difficult to get any compression, secondary lymphedema, toe infections, or anything. Number 8, mechanical tissue and nerve damage. Sounds very serious. We're suggest considering that, according to the law of Laplace, the local pressure below the compression may be higher than expected bony and tendinous prominences, such as above the ankles, the tibia, fibular head, or above tendons, such as the Achilles tendon, and to check those locations diligently for skin lesions due to pressure. One of the commonest tendons, of course, is the tibialis anterior tendon, which does take a lot of the brunt with prolonged use of perhaps compression material, tension devices, which are too tight. And this is because of the law of Laplace. A 22mm stocking is not 22mm on the patient. We know that if pressure equals tension divided by the radius, and if the radius is small, the pressure is very high. And these occur over the fulcrum areas like R1, Achilles tendon, and R2, the front of the gaiter region. And the patient on the left, you can see these sort of friction, these sores as a result of the compression. And the patient on the right had a horrendous ulcer over her anterior border of her tibia, which healed up eventually in line with this ulcer at the back. It's retrolateral malleolar, and this is in the R4 region. And this does have almost has no pressure at all applied on it because of the law of Laplace. So the pressure of the stocking is not necessarily the pressure that the patient receives. Recommendation number 9. To prevent tissue damage or necrosis and nerve damage in regions with a small radius, we suggest protecting these regions from inappropriate high pressure, particularly in patients with sensitivity, with decreasing the local pressure by inserting soft padded material and using a low overall pressure. So essentially what you're trying to do is increase the radius of curvature and protect the tension interface by displacing this tension interface away from the skin. This is often easier said than done. This is a horrendous case of compression-related dermatitis. If there's no compression, there's unlikely to be the dermatitis. We can see that there is this zone of demarcation once again with some post-inflammatory hyperpigmentation present. And this is the final slide. This is what happens if a patient with arterial occlusive disease has been given inappropriate compression. Most of the time with arterial occlusive disease, the lesions are gangrene of the extremities, the tips of the toes, maybe a toe, maybe a ray. But this is more proximal, and this has been caused as a direct result of compression applied inappropriately in a patient with arterial occlusive disease. It's the tension of the device which is likely to have caused this. Tension-free devices are very comfortable at very high pressures. and this lesion may not have occurred, but this is conjecture. Well, thank you very much for listening to me, and if you have any comments, please feel free to ask them.
Thank you. Thank you, Chris, for your brilliant presentation. It is time now for the poll. Do you prescribe medical compression stocking to decrease edema in your diabetic patient? And while we wait for the response, I would like to have a very short comment for your presentation. I mean, you showed us frightening pictures. I would like to reassure all the prescribers of stockings. Maybe Nick wants also to tell something on this. If you prescribe the proper stocking to the proper patient, all what you showed us is very rare to happen. Do you agree with this?
Well, absolutely, and I think I mentioned that in the very first first few slides, that the complications that I'm discussed are very rare, and the figure that's quoted is less than 1 in 10,000 patients. So I would entirely agree. But, you know, if you give a presentation about complications, you want to show the pictures, don't you? I mean,
no, you are completely right. But, you know, when you see a series of these slides, everybody thinks that every time you apply a stocking, something like that could happen. And this is not the case, luckily for us.
No, I quite agree with that. And I think that you probably would agree with me that the incidence of these types of complications are less than 1 in 10,000.
Perfect. So everybody will be reassured. And the result of the poll is that the majority of participants will apply compression for diabetic patient, but only specific diabetic compression stocking and after careful consideration. Okay, so at this time I would like to invite Nick Morrison to comment on these two presentations. Nick Morrison is a general surgeon by training, but since 1996, he has concentrated his practice on the care and treatment of venous and lymphatic disorder. You perfectly know that he is the past president of the IUP, and he was past president of the American College of Phlebology. He's a diplomat of the American Board of Venous and Lymphatic Medicine. Nick, please, the screen is yours.
Thank you, Giovanni. I'd like to go back, if I can, for my brief comment. I'm like Joe, I'm going to make this real brief. I'd like to go back to the previous speaker with respect to indications following intervention for chronic venous insufficiency. One of the problems in the United States is that insurance does not cover compression hose, for the most part. So everyone has to buy the compression hose themselves. So that really starts to weaken the patient's ability to comply with your recommendations. From the U.S., which I'll call the land of almost universal endovenous treatment for chronic venous disease, superficial disease. Traditionally, we have had the recommendation, a high-grade recommendation for the use of compression hose after endovenous treatment. That is starting to weaken a bit. There have been a number of recent studies that have come out, comparative studies showing that compression may not be necessary following endovenous ablation. However, in our practice, routinely, patients will virtually always tell us that they are more comfortable in compression than not. So the pain and the swelling is less, even though we can't demonstrate that on some of the studies that have been made. So that's my only comment.
Thank you, Nick. I fully agree with you. You know, in most recent papers, seems that compression after procedures is not important, but actually we speak with between us, everybody applies compression. So I think there is still a very big space for compression after procedure.
Oh, except Eberhard, he's got his hand up.
Yes. No, there's another point. You know, it's always thought now that you should do invasive treatment as much as early as possible, and then you can heal everything. And this is, I think, is not true, because we know that many of our patients have an improvement of their symptoms and an improvement of their situation. But look to all these severely obese patients, which still have side branches, which still have, let's say, impaired ambulatory venous pressure and things like that. They go on with symptoms and signs. And to say, just because they had a treatment, now you limit your compression for 1 week, that would be nonsense for me. I agree that for the intervention itself, if that is the indication for compression, 1 week of compression might be enough. But that is, the intervention is not the patient. If you look to the patient and he has still symptoms and signs of chronic venous disease, for what reason whatsoever, for age, for obesity, for other reasons, for immobility and so on, you should go on with compression treatment. That's what
Eberhard, I think that's an excellent point.
I agree. So, and we need to go on. I would like to tell Chris that he received a lot of congratulations for his presentation and some questions. The first one is why compressor stockings are often advised to be used during the daytime. Why it shouldn't be used for 24 hours, like anti-embolism stocking. Chris?
If you would like to answer this question. Yeah, it's using the daytime tends to be the time that our legs are gravitationally disadvantaged. And if the aim is to remove the symptoms and signs as a result of the gravitational stress on the leg, and since that during the day is most of the time that we are upright, then it sort of makes sense that it should be advised you during the daytime. At night, of course, when you're horizontal, if you sleep, provided you don't sleep in a chair, like many of my patients do, when I would advise that they wear them at night, but if you're horizontal in bed, then what's the point of compression for chronic venous disease? Lymphedema is a different thing, but what's the point of having compression when there is no gravitational stress on the leg? And if you want to use it for pumping, I mean, do you need your calf muscle pump at night?
Thank you, Chris. You have many questions, so we'll try to respond. A great presentation. How do you determine the level of compression to prescribe when there are arterial perfusion inadequacy?
I mean, it's an excellent presentation, and I think Professor Mosti, you did quite a lot of work.
Sorry, Chris, there is another very similar, so you can respond both. For mixed venous and arterial leg ulcers, which compression garment do you advise?
Well, the bottom one is easy, because I would advise the compression garment that produces high tissue pressures, but doesn't have the side effect of tension. So we have increased the pressure, increased the tissue pressure, increased the compression, but there is almost no tension present. So we have to move this interface, this tension interface, as far away from the skin as possible. Now, the first question, how do you determine the level of compression to prescribe when there's arterial perfusion inadequacy? Well, the PicoPress device is good, but it doesn't give us the full picture, especially around the fulcrum points. And the question you really need to know is how much of each, how much arterial insufficiency is there and how much perfusion inadequacy is there. Most of us don't rely some way on objective measurements, but how many people actually do tissue perfusion tests and studies for that level of compression? And to be very honest, most of it just comes, is a clinical judgment and what you've seen in the past and a gut feeling. For example, how much skin atrophy is there? Because that might be more important than a slight reduction in arterial inflow.
And then I see that you are looking at the question. There is another one. If someone has a DVT but doesn't know yet, so is not taking anticoagulants, is wearing compression stocking class 2 or 3 dangerous to them? And can the stocking make the clot move?
I think the pressure head of clot displacement, potential clot displacement, is massive every time we take a step, a leap, or a movement forward, or especially if you jump off a wall. Now that is far greater than any compression that a stocking could. So that's the case I would be worried. I won't say stockings are perfectly safe in this condition, but the evidence is very, very remote and scant as to whether stockings can actually make a clot move. I once saw a post-mortem of a lady that was run over by a car and it displaced a chronic DVT and caused a pulmonary embolism. So extreme pressures are usually required. And Valsalva, if the clot's not fresh, a Valsalva maneuver could easily move the clot forward with much more force than a potential stocking.
Okay, thank you, Chris. Maybe Joe, you have something to add to this? Unmute yourself.
I won't have any more long comments. First of all, it's a fantastic presentation. Despite how infrequent those complications are, everybody that takes care of legs should be well aware what can happen. The other comment I have is that I'm a very strong proponent in patients who have mixed disease to use a short stretch compression. And usually that means a Velcro device for most patients, because in that way, that usually works well. And if the perfusion pressure in the leg is greater than the resting pressure of the short stretch compression device, then they're perfectly safe.
Thank you, Joe. There is another question. I'm trying to look very quickly at the questions. Maybe we don't have time to respond to all of them. Maybe you can respond, type the answer later. And this one, is better to apply bandages to patients with ulcer than applying compression stocking, could need maybe one-day discussion. So I don't know if somebody want to respond this. Very, very shortly.
Well, I could respond. I mean, if you've got a horrendous ulcer that's all dripping all over the floor, then I don't think a compression stocking is going to do it, do you? Because it's all going to seep through and everything. If you've got a dry ulcer that's 2 millimeters in size and you apply a compression stock, I think if it works, it's comfortable, it's nicely fitting for the patient, we know that that heals ulcers. So I can give you the extreme examples.
Okay, and the last one, because we need to go on, and this is right for you, Chris, your recommendation for treatment dermatitis post-compression. So it is the really hot point. You touched it.
What is the question?
Dermatitis post-compression, how do you treat it?
Well, compression-related dermatitis, because of its definition, if you remove the compression, the dermatitis will go. But that's purely on its definition. However, you've got to be careful. It's a trade-off. I mean, how bad is the dermatitis? How much compression are you going to apply? If there's a small of it about, you might be able to lower the compression a little bit. You reduce the level of the compression pressure. and you do the tricks that were mentioned in the consensus statement. You increase the radius with pads, and again, what you do is you remove the tension interface by displacing it away from the skin.
Thank you, Chris. We need to move on. And it is my pleasure now to introduce Professor Urbanek. Tomasz is Professor of Vascular Surgery of the Medical University of Silesia in Katowice, Poland. He's the president of the Polish Society of Phlebology and member of European Venous Forum and American Venous Forum. He is also a member of the European Board of Phlebology and participates in many scientific and educational activity in Europe, including the EVF-HOW courses. In August 2019, he was the president of IUP chapter in Krakow, and certainly a lot of people remember how fantastic was this meeting. Today, we'll speak with us about risks and contraindications, part 2. Fedor, welcome.
Well, thank you. Either I am late or you're damn too early.
We are right in the middle of the webinar.
Okay. I was planning to connect like in 15 minutes, and then I see that you're all already there. Oh, gosh.
I'm very happy to see you because you certainly will help me in the chair in the session. So I will mute myself now.
What I'm going to do?
No. Now, Tomasz Urbanek has his presentation.
Okay.
Thank you very much for the invitation, this introduction. I will continue the description of the risk and contraindication of medical compression treatment consensus recommendations. There will be next recommendations discussed in a minute. Many of the things were already reported in the Chris presentation, especially this, I think, most important contraindications for compression treatment must be considered, and we should think about the side effects. Next recommendation is recommendation 10 that suggests the specific precaution, padding, special care of feet, low pressure use, pressure of the compression, and close control at the initial stages of compression therapy in patients with polyneuropathy, elderly patient, dry atrophic skin. So many of us apply this compression, but at least in my country, except the patient out control, in most of the cases, it's difficult to follow the patients and to see how the patient proceeds with the compression compliance and also what happens to the skin and to leg. That's why this should be probably the part of the information for the patient and the family, that in some group of patients, we can have the local skin and soft tissue complications related to the complication application, which sometimes is forget to tell to the patients and its family. This concerns especially the group of age malnourished or sun damaged skin patients with a low amount of the subcutaneous fat. And as Chris already mentioned, we have various factors which can be responsible. The law of Laplace is important if we compare the pressure on the prominences like bone or tendinous prominences to the flat areas. This can be the significant difference, and we should have this always in our mind. Reduce ankle brachial index or reduce blood supply, it's important. And then, of course, the position of the compression on the leg, including the possibility of strangulation or tourniquet effect, which can lead also to the tissue damage and also to compromise arterial flow. And of course, additional factors like severe POD or microangiopathy should be taken into consideration. This concerns also nerve damage. There are some places that are especially predisposed. In the lower legs, this is probably mostly the injury of the common peroneal nerve, but not always. However, the region of the fibular head is the place where we should especially focus, especially in the people not having much fatty tissue just the bone and skin to cover by the compression. And there are some cases described with the acute, complete or partial foot drop related to the compression. But as said before, this is not the group effect of the this kind of treatment. I mean, compression. It happens very, very seldom, and it's rather the case-related, patient-related complication which we can avoid. If we think about this, there are several causes of nerve damage, like incorrectly sized medical compression stocking, slipping and rolling of the compression, but also the group of patients which will not report these complications because of paraplegia or leg paralysis. That's why be careful if you have someone with paraplegia and you want to cure the and treat the swelling, because this patient cannot report really what happens as the nerves are already injured. That's why this patient requires periodic neurological assessment, and this is the recommendation 11, which summarized this, and that we suggest considering that pressure-induced nerve damage may occur in specific points of the leg, especially fibular head, mainly in the cases with excessive local compression pressure. All the reasons were previously discussed, and we should avoid high continuous local pressure in these regions where the nerve compression is possible. This is also important in relationships to the correct sizing and application of the compression. POD, there were 2 questions already about this. We have to remember that this is quite common disease, and also that quite commonly we treat the patients which are especially predisposed. Like often we treat old patients. Many of them will have the asymptomatic POD course presence. This is probably the most common presentation. High prevalence of diabetes, which accelerates the POD and ischemia progress. Many of these patients will have some limitations in mobilization and walking, and of course, many of them are obese. And we have 2 main issues regarding this. The compression can increase the risk of local soft tissue damage and necrosis, but this can also generally increase the risk of peripheral ischemia worsening. This was one of the last slides in Chris' presentation, that typically we have the necrotic changes in the patient with critical leg ischemia on the fingers and in the heel region. But if the skin is previously damaged, and if we have the ischemic leg, there is the possibility to have these skin injuries also in other areas of the extremity. What's the prevalence of POD? It's from 3 to 10% of the adult population, but significantly increase in the persons over 70 years. Right now we live longer, and that's why we should expect that this population will be really the target of the treatment also of the chronic and lymphatic venous disease. So we should expect these patients. And of course, we should have access, this is a practical issue, to some of the possibilities how to measure this. At least ankle brachial index should be available in the patient when we have the doubts use compression or not. And remember about the patients with diabetes, when incorrect ankle brachial index measurement can show you the value above 1.4, and this can be really ischemic extremity. And this is recommendation 12, that we should always check the arterial circulation status before any kind of compression is initiated. And if foot pulses or ankle pulses is weak or unpalpable, ankle brachial index should be measured. I would add to this also one recommendation, that we should really ask the patient about the claudication and possible clinical complaints, because there are many patients with pulse present on the foot arteries, and 50 or 100 meters of claudication in the case of severe stenosis. So various approaches have to be taken into consideration. Generally, for medical compression stocking, this is the absolute contraindication: severe POD with systolic ankle pressure 60 millimeters, mercurium and 2 pressure below 30 millimeters. It corresponds to the ankle brachial index below 0.6. but we speak about the contraindication to the medical compression stocking in general, speaking about these values. But what about the patients with the value of ankle brachial index from 0.6 to 0.8? And this was also already partially discussed. In these patients, if you don't want to use the compression, probably you will reduce the level of compression anyway in this group of patients. But if you have doubts what kind of compression can be applied between 0.6 to 0.8, there is the wonderful paper of Giovanni Mosti and the group showing and documenting that in this group of patients, you can successfully use short stretch compression. It means inelastic bandage with modified reduced level of compression below 40 millimeters mercurium. But there is another issue also mentioned by Chris, that who of us regularly measure the pressure when we apply short stretch compression to this patient group. However, this is an option for the patient with decreased arterial blood supply. So as we see on recommendation 13, which was already mentioned, the severe POD is for sure a contraindication for medical compression stocking, but this contraindication does not apply to some other sorts of compression like IPC or use of inelastic material like wraps or short stretch compression bandage. Recommendation 14, in every patient with impaired perfusion, we should carefully monitor the patients. So patients should be aware what can happen, and also the patient family should be supportive in this. And we should not forget to give such advices when we see these patients. Another group of patients which can be the problematic to apply the compression, there are the patients after vascular reconstruction. We have various clinical scenarios and situations. We can have someone after vascular reconstruction and with previous lymphatic and venous disorders, someone who has swelling because of grain incision and lymphatic system injury, local hematoma, healing process, ischemia and reperfusion, postoperative DVT, infective complication, immobilization. This all happens in daily practice. If you work in vascular surgery outpatient department, you see this patient quite regularly. But there is the important question, can we use medical compression stocking after bypass procedure or any kind of other vascular reconstruction like PTR or stent placements regarding the level of ischemia, so low ankle brachial index or low peripheral perfusion. There were previous recommendations talking about this, but for us also location of the bypass and its anastomosis is important. Because we know that we have anatomical and extra anatomical and also proximal and distal anastomosis locations. And there are some advices where we have the higher or highest risk of the bypass occlusion by decompression. This happens especially if superficial bypass location is present. We should be aware when we see the patient with so-called in situ venous femoral-popliteal or femoral-distal bypass, because this is above the fascia and it's quite easy to compress. And the patients with very distal lower leg bypass anastomosis, which is at the level of ankle or below, because there is a lot of, that can be problematic because of low amount of the soft tissue and usually very superficial location of this anastomosis, especially distally. We should be aware about the situation when we have improper shape of the extremity and the stocking can make the tourniquet effect, because this can in reality close any also anatomically located bypass, which is inside the leg between the muscles. And of course, if we use too high-grade compression, which can be very effective in bypass closure. So various factors has to be taken into consideration. This is summarized in recommendation 15, that after bypass surgery with improved peripheral arterial pressure, medical compression stocking may be performed if there is no direct compression effect on the bypass itself. So we can have the compression in the patient after aortofemoral bypass if we have the proper blood supply to the distal part of the leg. I don't see any problems. We can have below the knee compression in the patient with femoral popliteal above the knee bypass if we see swelling, but the distal pulses are present. We suggest avoiding the compression of epiphyseal bypass conducts. This is the situation when we have, for example, the in situ femoral-popliteal femoral bypass present. And of course, all recommendations regarding chronic leg ischemia should be followed. And classic recommendation in this part of the lectures, our common indications to wear medical compression is deep vein thrombosis prevention treatment, post-thrombotic syndrome prevention treatment, and also superficial venous thrombosis treatment. But in some cases, if we see the patient with tourniquet effect, the medical compression stocking, if improperly applied, can cause the venous stasis. That's why in these patients, we have to be careful because we can provoke one of the part of the Virchow's trial, circulatory stasis. And this is recommendation 16. Because of tourniquet effect, improper compression can cause local, should be probably venous obstruction, but in most of the cases, we will see superficial vein thrombosis if we see the tourniquet effect above, for example, big varicose veins, especially in combination with other factors like prolonged sitting, like a long distance flight. So if we see the patient after first visit with the compression applied, we should see how this looks on the legs, because not all these patients will recognize the strangulation or tourniquet effects on the extremities. So to summarize, we should respect contraindication and precaution, but we should also be aware what remains the real and absolute contraindication to use medical compression stocking in 2020. And this was already mentioned, but Eberhard, I just wanted to summarize this, that this what is right now, the absolute contraindication for the medical compression stocking is really severe PLD, epiphyseal arterial bypass presence, confirmed allergy, but this is also perhaps not absolute, but should be taken into consideration. Severe diabetic neuropathy with sensory losses or microangiopathy with risk of skin necrosis. And the next two, severe cardiac insufficiency, will be discussed by in the wonderful talk of Tobias Hirsa. I will not prolong. Thank you for attention. Thank you very much.
Thank you, Thomas. Thank you for your brilliant presentation. And I would like give the mic to Fedor to lead the discussion and to present the poll. Fedor.
Oh, thank you, Giovanni and Tomas. It's an excellent talk. There are quite a few questions from the audience. Two of them are directly relevant to your talk. One is asking, what specifically can you do when you detect the nerve damage? And the second is asking whether that's any medical treatment for that condition.
It depends on the nerve severity. We know that in some of the patients, we can expect reinnervation of the nerve, but in reality, this is the complication of the medical device. That's why fortunately, I never had such a complications like nerve injury after compression, but for sure, this is the first point to avoid using compression at the same location. So this should be avoided, and perhaps we should change into other sorts of compression, which will be better controlled in regard of possible compression. And then, of course, it's symptomatic treatment because, as we know, the level of paresis nerve injury can differ between the patients from some sensation disturbances to the complete paresis. We know the time of reinnervation is much longer. For sure, I would send this patient to neurologists to help us with the diagnosis and treatment. However, if happens, it's one of the most severe complications which can really make problems not only for the patient.
I saw Dr. Caprini raised his hand. Do you have a question, Joe?
I wanted to make a comment that although a beautiful presentation, by the way, Tomas, fantastic. When you have a revascularization of the lower extremity, a fem-pop bypass for a critically ischemic limb, there's reperfusion edema, which often occurs. And I see my fellow vascular surgeons always putting ace bandages on that, and that's a nightmare we've very successfully used either short stretch compression or better yet, a Velcro device that can be loosened if there's any changes at all. And we found that to work very, very well for post-vascularization edema from reperfusion of an ischemic extremity.
Professor Caprini, I think that this is a very important issue, and most of the vascular surgeons don't think about this problem at all. I see this also in our country among my friends, that swelling after revascularization is something normal for most of the people. But we have some ways to help this patient, of course, if this is not the factor making an impairment of the arterial flow. We can use intermittent pneumatic compression. We can use, of course, this short stretch bandage or the wraps when the patient is mobilized, of course, because this will be not for the patient that is still lying after the reconstruction. If we tried, and I tried personally in this patient who are in a bed, not mobilized yet after the reconstruction due to critical ischemia, intermittent pneumatic compression to decrease the swelling. And as far as I know, some of some of the results of such studies are published in the literature.
Tomasz, since we start talking about this issue, I would ask you another question. So what we see very frequently after vein harvesting swelling, and that's mostly done by our cardiac surgeons colleagues. So what kind of compression would you use, and what testing would you done before you use compression?
I see exactly the same. They don't care what happens. Usually they send the patient to the outpatient department if there are some problems with healing, and these problems with healing are related to swelling which occurs in this patient, which compromise the wound healing. And many of these patients comes with really big infected wounds. There are few generally in the big population, but it happens, it makes a problem. So if we have the proper distal pulse in these patients, I think that for at least the first period of the treatment, class 1 compression, I mean something that will be tolerable for the patient, can be applied. More problematic are the patients that have the multi-vessel disease, so not only cardiac problems, but also PID. And many of these patients really have concomitant leg ischemia, which makes this problem more severe. But I think it's case dependent, and I see the patients with these problems like once in 2 or 3 months, and most of this patient gets compression. If there is the impairment of the peripheral flow and we have the problems with wound healing in the below the knee level, I use the short stretch compression.
Thank you very much. So I would like to open the panel discussion by introducing Dr. Molay Patel. Dr. Patel ended his academic career in the Gujarat University, transitioned to private practice. Recently, we all know him as the president of the Vascular Society of India for a number of years, then vice president of International Union of Phlebology, and now he's serving as Assistant General Secretary, or will be serving as Assistant General Secretary since next year. More important things about Molay is that he describes himself as a phlebologist enthusiast, which is really true regarding his activities that cross over all fields of venous diseases and lymphatic diseases. So Molay, please.
Molay, unmute yourself.
For being here, and good evening from India.
Okay.
And it's unmuted.
Molay, we hear you, but there are some connection problems.
Can you see me here?
Yes.
Yeah, since Molay is fixing his connection problem, I will just open for the entire panel discussion. Oh, Molay, are you here? You connect?
Can you hear me now?
Yes.
Can you see me?
Molay,
Yes.
Perhaps you switch off your camera, then we have better connection, and then we will hear your voice.
Good. Okay, can you hear me now?
Yeah. Yes. Go ahead.
Okay, these were wonderful presentations about these contraindications found, though rare. And first of all, I'd like to really sincerely hope that none of us sees those serious forms of the complications like the tension-induced skin stress, the compression-related dermatitis.
Molay, we lost you.
In India have encountered them a little more frequently than what you see in Western countries. And possibly that's because we have a warm climate. And in June 2019, a publication, well, I think Peter, just go ahead. My connection. Just go.
Peter, we probably should continue as Molay does not have the connection, so.
Right, well, let's continue then. Molay, you can try to fix something and we'll see if you can reconnect with us. Probably it's better to disconnect and reconnect again. So I will open it to the entire panel. Any comments? Chris, I will start with you.
No, further, Molay just reiterated the terms that are probably not that well known, which are distinct clinical entities. One of them was tension-induced skin stress, and they were the bands and lines that appear after perfectly fitting stockings or bandages are removed. And the other one was compression-related dermatitis, which is the condition where the stocking has some effect in creating the sort of skin change. And I think what Molay was sort of saying, because what is a bad connection, these conditions are much more frequent in India. And I was going to ask him, is there any special messages that can be said from this in India as to how to attempt to remove these or minimize these complications?
Any comments on this, Thomas?
I think that you know, we live in various environments, and I think that most of us here in north of Europe do not deal with the complication as we see in hot countries, especially. And for example, I saw many presentations about the compression from the colleagues from the south countries, from Europe and also other continents, where this really becomes the problem because not all people can use air condition. And Giovanni, you are from Italy. Is there any problem to use compression in Italy as you have, you know, the high temperatures starting in May and finishing end of September? How you deal with this? Because this in daily practice should be very difficult. In Poland, if I have the temperatures like now, 30 degrees, which is quite cold for Italy, no one wants to wear the compression. And also much more patients present with some local skin complication because of, this was Chris mentioned, I mean temperature, pressure, and this wet tissue under the compression stocking. So how to deal with this?
So Thomas, the heat is a very big problem everywhere, I think. In Italy, we are not certainly in the most hot country in the world, but even here we have big problems, especially during July and August. Everybody doesn't want to wear stocking or any other compression unless they have very severe disease like DVT or ulcers, so they are obliged in some way. But if you look at people with varicose veins, with some edema or some pain, minor symptoms, I would say, no one of them were stocking during July and August. And it is a big effort for us to try to convince them to wear at least, so so to say, compression with less compression pressure, or microfiber with different textiles, but it is still a big effort and unfruitful effort, I would say, because I'm convinced that 95 of my patients during the summer don't wear stocking at all.
Well, I would ask Dr. Morrison first, because he is actually is much hotter place than in any one of us in Arizona. What's happening there in terms of wearing stockings during the summertime?
Today will be 48 degrees, so it's very hot. The thing about the U.S. is that everything, okay, Joe, everything is air conditioned. The car, the home, the office. Terry has to wear a sweater when we go to a restaurant or a movie because it's so chilly in there because they keep it so cold. So it's really a different problem. I still think, however, that education, and re-education is so important. When the patient comes into the office, everybody should be wearing compression hose and be able to show those compression hose. That's really the key to it.
Eberhard.
I have for my patients, I advise them, if it's so hot, pour some water on your stockings and you will have a cooling device because the water will vanish and the skin will be cooled under your stockings. And for most of the people, they can do that, and that's very easy. The other point is, it's better with stockings than with bandages. If you have, for instance, a 4-layer bandage for a whole week, and you have these problems of dermatitis below a long-term compression bandage, that is a real problem in a hot circumference. And that speaks for putting more stockings, even for as low pressure as possible stockings to your legs, and just cool it by pouring water on it. It may help.
So, but for the all panelists, but the real question is not really about the compliance, but whether wearing the compression in this climate cause any complications that we don't really see otherwise. So let me start again with Giovanni. Do you see any of those, or how frequently do you see those complications specific to the heat and compression?
No, as I told you, I don't see many complications because
they don't wear stockings.
Yeah, in our country, as I told you, unless you have a very severe problem, nobody wear stockings during the summer, because differently from you need also to consider that in Italy, we have 7,500 kilometers of coast. That means beaches and sea. And a lot of people here spend their holidays in the beach. So put together summertime, hot climate, humidity, and beach, and you can understand that nobody wants to wear stockings. But luckily for us, this is very limited to July and August. Usually people wear stocking up to June and start again in September. So the time of no wearing stocking is very, very limited.
Yeah. Eberhard, so you actually suggested a few solutions to the patients. Are they still wearing them, and do they have any complications related?
Yeah, I think Germany is Germany didn't used to be so hot as a country. Now it has changed a little bit, but compliance in Germany and also in the Netherlands is much higher than the United States or other countries, I think, from the data we have. So people are quite compliant. I would not, sometimes our understanding of compliance is very strict. That means you should wear your stockings 8 hours a day. You start when you get out from bed and stop stockings when you go to bed again. For me, this is not compliance. Compliance is you put on your stockings when you need it. If you have a standing profession and in this time you have a swelling And in the rest of the time you don't have a swelling, put on your stockings when you have your profession and you are standing. And if you modify your compliance understanding, it is much more convenient for the patient. And as I said, if you go to complications, even in the hot temperatures, this is a problem of high compression, permanent compression, day and night compression, several days of compression bandages, more than compression stockings. Mm-hmm. And as I said, just pour some water on your stockings. You can try this. It's really nice.
So to summarize, Thomas, before you go, I can see the consensus among the panel members regarding these complications related to heat is, number one, try to find some solutions that still work in the high temperature. And as Eberhard mentioned, intermittent use of compression in the situation when you really need it, and avoiding compression when you don't need it and the temperature is too high. Those are solutions to prevent those complications. Thomas?
I have a question to Giovanni, because most of us follow your research regarding the short stretch bandage in this patient 0.6 to 0.8. But what's your personal feeling about using compression in reduced pressure amount in these patients? Because we know that using the short stretch bandage is quite complex in some of the patients, and my personal feeling is that there are the patients which benefits also from the reduced stocking, of course, reduced pressure stocking, of course. There is the question how to choose the best patient for this. This should be patient who is aware of the complications, who is controlling the local condition of the skin, and who is controlling this, because we cannot apply to everyone. Do you use the compression in a daily practice in the patient with the ankle brachial index below 0.8 in the patients who requires compression, I mean medical compression stocking? What's your personal approach?
So, Thomas, in these kind of patients, obviously I don't apply any compression if they don't need, because if they have just varicose veins, asymptomatic varicose veins, there is no reason to apply compression. But if I have serious problem like severe edema or leg ulcers, I apply compression for sure, even if the ankle brachial index is below 0.8, but it must be higher than 0.6, and mainly the perfusion pressure must be higher than 60 millimeter of mercury. In this case, usually apply inelastic bandages, but if they have just edema problems, stockings are perfect, and I use stocking without any problem. You need to be sure that the perfusion pressure is correct, because is enough, because obviously if you have a perfusion pressure higher than 60 and you apply, I would say, a stocking exerting 23 to 32 millimeter mercury, you are absolutely on the safe range. Don't forget that this is the pressure at rest. So when the patient stands up, the pressure goes up to, if he has 60 millimeter mercury in supine position, it maybe have 150 millimeter in standing position. And when you apply a stocking of 23 to 32 millimeter mercury, second class European stocking, you're absolutely in safe range. Your standing pressure is much higher. And we know that compression is mainly used during the daytime, not certainly at night. So I use compression without any problem.
Chris?
Yes, if it's possible to ask Professor Caprini a question, I'd like to really hear his views on this. It's moisture goes along with heat very often. And what does he have Joe Caprini, do you have an opinion as to whether we should apply all these lotions, potions, ointments, creams, gels for dry skin underneath a compression stocking? Do they do more harm than good, or is every case an individual one?
Well, I think that there is, of course, individuality, but as a general rule, proper moisture balance is good. Now, under my short stretch bandages, I usually will use something like a Webro to wick away moisture and so forth. And and certainly in ulcers, you have to have ideal wound balance. And I would say that one of the things that we found very, very helpful in the problem patient is to use a cotton liner and a Velcro type device over top of it. And in that way, we can very nicely control things. If the patients go out and they start to perspire a lot, they can whip off the Velcro and go ahead and, you know, in that way, it's much more flexible than having to have them don and doff a stocking.
Yeah. So moisture's a bad thing, really.
Yes. Now, one more thing I want to say while I have the floor here is that in serious patients, sometimes what we will do is we will take a look at the perfusion pressure in the leg. If a patient has hypertension and the 0.5 index, they still have a pressure of 75 or 80 millimeters of mercury at the ankle on direct measurement, then I think those patients, even though it's 0.5, do very well with short stretch compression. Very, very reluctant to go with elastic compression, but not with short stretch compression. And again, we found the Velcro very, very helpful. Patient has any signs or symptoms of cramping, pain, aching, they just loosen the straps and usually everything works out well. Another thing is that, don't forget, in people with ischemic limbs, sometimes we use the Artisist device to temporarily flush as much blood out of the venous system as possible to allow a little more arterial perfusion in there. And I would suggest that when you're walking with a short stretch component, you have a mini equivalent of the Artisist type effect.
Yeah.
Joe, I would like to thank you for stressing the concept of perfusion pressure, that from a compression point of view is much more important than IBPI.
And if I allow to make some comments, because I think it's extremely important, two issues that were raised. First, creases by humidity and the skin, they are not really connected. I mean, we have right now, we have 40 degrees in Toledo and 80% humidity. And believe me or not, a lot of patients have a very dry skin. So it's not, the issues, those are not related directly. It's more conditional with skin of a patient rather than environment. Of course, they did it. But the other thing is, I really want to point out to everybody that ABIs, perfusion pressures, and all other tests that we commonly use, with a few exceptions that I'm going to measure, are only addressing macrocirculation. So the most of the complications of the compression relate to microcirculation in the skin, and those tests do not directly assess that. So if you really want to look at the skin level, you really need to measure either transcutaneous oxygen pressure in those areas or in skin perfusion pressure with a laser Doppler, not the ABIs or perfusion pressure. Of course, they are related, but it's not a direct relationship. So some patients with relatively low perfusion pressure of 40 millimeters mercury can actually safely tolerate compression. Other patients with perfusion pressure of 70 or 80 may develop some complications. So it's not 100%, it's not black and white.
Further, you're completely right, but the problem is that not many laboratories have the chance to measure laser Doppler or ABPI, or sorry, yes, or transcutaneous oxygen perfusion. So at least we have some hints, at least.
Yeah, you're absolutely right, Giovanni. Very few laboratories do that. Sylvain, you have a question or comment?
I'm really sorry to interrupt this lively discussion, very interesting. In the sake of time, I just wanted to ask maybe the organizer to present the poll results so that we can just have a quick look at that before we continue with the last presentation. Thanks a lot. So we see here for the question was cardiac insufficiency itself does not constitute a contraindication for compression therapy. In which NYHA stage would you consider to use the medical compression stocking as being contraindicated? So there is not an absolute clear result here. So 42% for the classes 3 and 4. 38% for class 4 only, and 90% even think that never for all stages and cardiac patients. So I think it's time to open the scene for Tobias to talk about this. Thanks a lot.
Giovanni, I'm muting myself.
Yeah. So the last presenter is Professor Hirsch. He's a specialist in internal medicine and subspecialization in angiology. He practiced for internal medicine and vascular disease in Hull. He's very much involved in German Society of Phlebology of Angiology, and is the next chair of the this year Congress of the German Society of Phlebology. He will speak today with us about risk and contraindications again, specifically focused on borderline indications. Please, Tobias.
Thank you very much for this introduction. It's a great pleasure for me to join this meeting and even to be part of this expert group. Can you see my presentation?
You need to share your screen.
Now you can see my presentation, isn't it?
That's perfect.
It's my task to explain how cardiac insufficiency influences compression therapy. I will talk about blood volume shift, compression-induced volume overload of the right heart and its compensation mechanisms. And finally, I will give you some information on borderline indications. My conflict of interest. This is Anna von Bötticher. She is Germany's most famous female freediver. 20 to 25 meters are usual depth for divers. The world record is around 150 meters, and 20 meters translates to 1,500 millimeters of mercury, which affects the whole body. However, this is not an issue for healthy individuals. This friendly lady is Ottilia. She's 75-year-old, and she's not healthy. Instead, she suffers from coronary heart disease, atrial fibrillation, and it's heart failure, NYHA stage 2. And another problem is she has a lymphedema in her right leg. The question is, can she receive compression therapy and lymphatic drainage in spite of her heart insufficiency? Usually the causes of heart failure are hypertensive heart disease, coronary heart disease, heart valve defect, cardiac arrhythmia, and myocarditis. Affected persons suffer from dyspnea, nocturia, fatigue, cyanosis, and bilateral edema. The most critical symptom is dyspnea, since it is potentially life-threatening. We distinguish between 4 degrees of heart insufficiency based on the International Classification of Diseases. Grade 1 means there's no limitation and symptoms under normal activity. Grade 2 means slight limitations, but beginning symptoms in ordinary activity. Cardiac decompensation starts at grade 3, but patients are still comfortable at rest. And when they reach grade 4, patients are unable to conduct any activity. They also have symptoms at rest. When is it imperative to stop decongestive therapy? This is what I call my compression homunculus. We see the venous pooling in the legs, the right atrium and the right ventricle, and we see the left ventricle with the arterial branch, and these are the lungs. Blue indicates water. Edema, and now observe the vein of the leg and the right heart once I put on a compression stocking. In the worst case, a pulmonary edema can develop, and this is the problem. The redistribution of blood volume was measured in 1978 by Mosbeck and Hugo Parch using scintigraphy. They applied a 25 and 40 millimeters of mercury compression using a kind of inflatable rubber boot. They found that the blood volume of the leg decreases by 33 to 38% depending on the pressure, but the extension of the blood volume in visceral organs was just 6 to 7%. Chris Latimer et al. Used air plethysmography to determine that there is a volume displacement of about 40 milliliters per leg when below knee class 1 or 2 medical compression stockings are worn. The point is that only a fraction of the blood reaches the right heart because of the elastic properties of the inferior vena cava. In addition, changes in heart rate adjust the cardiac output to compensate for the increased load. Now back to arterium. Are we allowed to mechanically decongest? The European guidelines for heart failure published a list of factors that cause decompensation of heart insufficiency. They don't list compression and lymphatic drainage. We have to establish this on our own. Patient history is always the most important thing. We can ask, do you suffer from dyspnea? Can you sleep in a flat position? Did you tolerate lymphatic drainage and compression stockings? Do you suffer from breathlessness? And then we have the examination, bilateral edema. And this is typical for a heart failure. There's another very good tool, NT-proBNP, a biomarker that marks the cardiac burden. The normal NT-proBNP rules out heart failure. This is a German review from 2017 with the limit values. You see that it also depends on the patient's age. Based on this, we can feel free to treat Our Lady, which we did. We have little data about biomarkers and compression. This is from Professor Wiener in Aachen from 1996. He used HANP, which is related to BNP and NT-proBNP. The marker rose only a short time with NYHA2, not yet decompensated, but all patients indicated a stable hemodynamic and cardiac function. So they concluded that the compression therapy is considered to be harmless in patients with cardiac insufficiency, NYHA stage 2. This is a paper from Belgium. They investigated NYHA 3 and 4 patients in an intensive care unit. They applied lymphatic drainage, intermittent pneumatic compression, compression stockings, and compression bandages, and measured using echography as well as a right heart catheter. They concluded that lymphatic drainage would be possible for these patients. But a note of caution regarding lymphatic drainage, they only treated in this trial the lower limb, and they did it in an ICU. This is from Israel. They investigated seating-induced postural hypotension in older patients with a decompensated heart failure. It's maybe a kind of a borderline indication, but the most important message for us is no cardiac decompensation at all when using compression stockings. On the other hand, there are case reports like this: acute pulmonary edema associated with placement of compression stockings. Cases like this suggest that compression stockings should be used with caution in patients with limited cardiac reserve. Let me conclude. According to our paper, if stage 2 patients are treated using medical compression stockings, we see a temporary increase in natriuretic peptide, but no hemodynamic changes. That means no risk at all. In stages 3 and 4, multi-layer bandages cause increase of right heart pressure without long-term impairment. And lymphatic drainage is no contraindication either. The take-home message is in patients with edema and cardiac insufficiency, compression therapy should begin with reduced pressure on one lower leg, progressing to stronger pressure applied to both legs. In stages 1 and 2, there are no restrictions on the kind of compression that can be administered. In stages 3 and 4, compression therapy can be carefully applied to a limited degree if there is a strict indication, clinical and hemodynamic monitoring, and if it's administered in an inpatient setting. However, we warn against applying compression in severe cases of cardiac insufficiency, stage 4. We also discourage the routine application of compression stockings in stage 3 cases. When needed, careful use of compression therapy in these patient groups may be entertained if there is a strict indication with clinical and hemodynamic monitoring. I would like to add some words about borderline indications. Clinical situations in which compression was previously considered to be contraindicated. In Europe, compression is routinely applied in the event of acute superficial or deep venous thrombosis, but this is not a common practice in all parts of the world. Instead, there is a theory that it might promote clot dislodgement and that it can cause pulmonary embolism. It should be noted that this theory is not backed up by any evidence. There is no difference in outcomes between compression and walking on the one hand and bed rest on the other. Early mobilization does not increase the frequency of pulmonary embolism compared to bed rest in Dvt patients treated with anticoagulants alone. In the case of superficial vein thrombosis, we even observe a faster thrombus regression with heparin and compression therapy. We recommend considering that in contrast to previous concepts, compression is not contraindicated in acute thrombotic events. but results in favorable clinical outcomes when applied with caution. In the hand of experts, proper compression leads to an immediate improvement of pain and edema, and this is very important too. Compression is the most effective way to reduce edema from any cause whatsoever, but it must be carefully administered for some indications such as heart failure, diabetes, lymphedema, arterial disease, and after arterial bypass surgery, as you already have heard by Tomasz. What about inflammatory skin disease? Erysipelas, cellulitis, and vasculitis were considered contraindications to compression because of the risk of circulating bacteria, but they may provide synergistic effects to antibiotic treatment by reducing inflammation, improving lymphatic outflow, and decreasing swelling. So we recommend additional compression in purpura due to leukocytoclastic vasculitis and in leg erysipelas and cellulitis to reduce inflammation, pain, and edema. In infectious inflammation, we suggest compression only in combination with antibacterial treatment. The last recommendation is special precaution have to be taken if compression treatment is considered in patient with borderline indication. Treatment decisions should be taken in a case-by-case basis and under consideration of a careful benefit risk assessment. Last but not least, I want to invite you to our German annual in a couple of weeks, which will held bilingual and as an online offer as well. So take your cell phone and scan this QR code and be welcomed in Leipzig this September. Thank you.
Thank you, Tobias. Brilliant presentation, really. I didn't expect you to suggest us to use compression even in NIA class 3 and 4. So something very interesting to know now.
It's important. These were examinations with patients on ICUs. But we have an opposite situation in our practices, as we see a lot of patients in an outpatient treatment. And these patients, only in very rare cases, suffer from decompensated heart failure.
So I don't know if we have, I see you, Chris. I don't know if you have, maybe Sylvain could help us. We don't have any more.
That was the last poll for the last one. So
perfect. So Chris, I saw your right hand.
We should repeat this poll.
After it, that's a good idea next time.
Yes, Giovanni, it was a question to Dr. Tobias Hirsch, if possible. I really enjoyed the compression homunculus, and it's discriminated between blood in the veins, venous blood in the leg, and the water around the outside and the effect of the compression. And it gets you thinking is that if you want to have some confidence in giving cardiac patients compression, it would be possible to do a challenge test. I am sure that you lie the patient down and you lift their legs to 45 degrees. That will have the effect of discharging nearly all the venous blood in the leg. And if the patient doesn't have any symptoms of pulmonary edema within about 5 minutes or so, then it's safe to wear the compression. I'm not too bothered about the fluid in the legs because compression prevents the formation of edema. It doesn't squash the edema back into the circulation. And if somebody, and it's a slow process to prevent the formation of edema. And if a patient has perfectly working kidneys, it should be able to pee all this out before it has any detrimental effect. Thank you for the presentation.
Fedor, you raised your hand. Fedor, do you have any comment?
Yeah, yes. Chris, you're absolutely right and wrong at the same time when you're saying that you know, the compression doesn't reduce the edema. It does substantially. And what you're saying about the patient can urinate, this is exactly the problem with patients with lymphedema, for example. When we put them in IPC in the office, the one thing that happened immediately after half an hour is they rush to the bathroom. And that's where we start testing the kidney function before we're applying compression to these patients, because you can actually cause substantial complication by applying compression to these patients. So it does reduce edema substantially, and the kidney function is a key here.
A challenge test, good thing to do. Elevate the leg.
Yeah.
Good.
Eberhard.
Just an information concerning one of your last slides, Tobias, on cellulitis. Alberto Caggiattis, just from Roma, just sent me the paper from the latest New England Journal of Medicine yesterday, which is the first paper I know on the proof that compression treatment in recurrent cellulitis patients reduces recurrences, the recurrence rate. We all do this, you know, usually, but they proved it in a study from Australia that if you apply compression treatment in a patient with recurrent episodes of cellulitis and compare this with a group with no compression, then you can reduce the incidence of recurrent cellulitis phases by more than 50%. It was a small study, it was not a multi-center study, but at least it was published in New England Journal of Medicine, and we have quite now some evidence also for our recommendations to use compression in those patients. It's good news for me, so. Just.
Sorry, doctors, if you would like me to relaunch Polling 3, I can relaunch it again. Would you like me to relaunch it?
That could be nice.
Okay, here you go. Please inform me when to stop.
I think that should be fine. Let's have a look at the results. Okay, looks still very similar to what we had before, as far as I remember.
The same as before.
Yeah.
Khaled, do you show us the new one or the old one? The new results or the old results?
The new results, doctor.
Okay.
Okay.
So there is still a lot of people afraid of compression in the NIA class 3 and 4, stage 3 and 4. Tobias, do you have any comment?
I think in both stages, 3 and 4, it's necessary to work with caution. Yes, you have to examine your patient and you have to know his patient history. And maybe you have to choose a stationary setting. Maybe I think these patients can be treated using compression. These patients can be treated using lymphatic drainage, but these cases must not be treated outpatient. They have to go into a hospital to have hemodynamic monitoring or clinical monitoring. You need breaks between the sessions of treatment, and you need the opportunity to stop in every moment. And this is what you only can do in a clinic, but not with the patient at home.
Would you be confident to apply, for instance, a first-class stocking that is still effective in edema reduction, but not so effective as a strong bandage, for instance, and leave the patient at home? So a very light compression just in one leg, even in a patient with advanced stage of cardiac recompensation, could be safe to keep at home, or you like?
We do check the anti-pro BNP in our practice, and so we apply the bandages or apply the stockings in our practice, and do a measurement half an hour later, and wait for the patient to say how does he feel, and if he feels well, he can go home.
Okay. So anybody has any comment?
Giovanni, I actually have a question for Tobias and for the whole panel. So compression in DVT patients, what specifically you use as a compression device? And I'm thinking about two different categories of patients. One is ambulatory patients that can ambulate, and the second category of patients that are immobile patients for whatever reason. They are immobile not for the reason for DVT treatment. But what kind of compression device, what pressure would you use in those two categories?
So from my point of view, I use first bandages, but just for one very practical reason. If you see the patient with a DVT in your office and you prescribe a stocking, he needs to go to the shop, he needs to have the stocking ready, and this is not always simple. Maybe they need to wait for 2 or 3 or 4 days to have the right stocking. So if you just apply immediately a bandage, the patient is protected, so to say, and then you prescribe a stocking and he has the time to get the stocking. These are just from a practical, very practical point of view. I don't do any difference between ambulant or immobile patients.
Yes, that's the same.
My attitude maybe is not correct, but it's just I don't have any data on this.
In Germany, we don't have stockings in the doctor's office, and that's why we have to apply compression bandages. The other thing is that the patients with an acute DVT, they indicate a swelling, and you cannot apply stockings if there is the edema, the swelling of the DVT, and that's why we apply compression bandages, and then we give him a prescription to buy the stocking once the swelling has diminished.
Yeah, the same for us. So I see that Hugo is trying to connect, or maybe I'm wrong, but I see him on the screen. Is it correct?
I tried to write you something.
Hugo, welcome.
Welcome.
I know you are behind the line, but we are very happy that you showed us.
That's very kind of you. As you hear, my voice is broken and I didn't want to disturb your discussion. So this was excellent from my side.
So do you have any comment?
No, you did a perfect job. Thank you so much.
Oh, thank you. Thank you. Okay.
So may I make a comment?
Yeah.
We were talking about patients that come into the office oftentimes, and I agree with everything that was said, is that we find oftentimes if they have some swelling, I'll put them in a short stretch bandage and bring them back, and then send them to the fitter, and they get a much better fit because that initial edema that you can knock down with one application of a short stretch bandage gives them a much better fit, because a lot of that initial edema will go right down. So I prefer doing that. Not in all cases, but in many cases where there is swelling, it might change the sizing. And also the type of stocking, you know, there are different sizes of stockings. Some have dimensions that are different than others. And so that helps the fitter as well.
Now, Joe, you are perfectly right. But I would like also to add that now we have Velcro wraps also. And so this is another very good indication for edema patients, because they can have Velcro wraps and they can have these very easily, and they can also readjust the size depending on the leg edema reduction. So this is another very important option, and I think you agree with me.
So I just want to say one thing. In 1983, I walked by this booth, and I was walking along with John Bergen, and I said, John, that's the most ridiculous thing I've ever seen. And he said, Joe, you go in there and learn about those devices, because they're going to save thousands of patients. You're going to use them in thousands of patients. And he was so right. I've been promoting these since 1983, but oftentimes they tend to be expensive, and not everybody will be able to go and get them right away. And so it all depends, but I'm sorry, the devil made me do that.
No, but you know that Sigvaris has an excellent Velcro wraps now, so there is no conflict of interest. They are very interested in wraps also, not only stockings.
Giovanni, may I make a comment?
Yeah, absolutely.
The rapidity with which the edema resolves with compression, with short stretch or inelastic compression, is probably not appreciated by many. It can be reduced within a matter of minutes to hours. When we see on our annual trip to South America, when we see patients with really significant edema and we need to get a decent fit for their compression hose, we put them in a short stretch wrap and have them walk about the town where we're working, and they'll come back in 1 or 2 hours, and the diminish is dramatic and quick.
Yeah, you are perfectly right. But this is exactly what I wanted to underline. Inelastic bandage first is very important, to my opinion. First, because it is immediately available, because in our office there are inelastic bandages. We cannot sell stockings. On the other hand, the immediate reduction with the inelastic bandages allow the patient to choose the proper size of the stocking immediately afterwards. So for these two reasons, I think that this attitude is important and right. But on the other hand, we cannot forget that from a theoretical point of view, elastic stockings are very effective in reducing edema. The problem is that if you apply a stocking immediately, maybe after 1 day, the patient needs to buy another one because the leg is dramatically reduced and the first stocking is not anymore effective. And from this point of view, I think you are right. And the correct attitude is apply it in elastic bandage or a Velcro wrap at the moment of diagnosis, and then of the visit of the patient, and immediately after, when the edema is removed, try to prevent recurrences by elastic stockings.
I think that's exactly true for severe edema.
Yeah.
If you look to all edema patients in your patients group, I would say 80% or 90% of the edema patients have low-level edema. And for those low-level edema, where you have, let's say, an increase of your leg circumference from 1 to 2 centimeters, you can immediately start with a stocking without changing.
Eberhard, you are more lucky than me. I don't see patients with little edema.
Giovanni, you muted yourself.
I'm just saying that Eberhard is more lucky than me because he's able to see even patients with a light edema. Maybe in my region, the general practitioner treat this kind of patient and send me only patient with severe edema. And so this is the reason why I have this attitude, but you are completely right. And you know, we also published a paper where we could describe that stockings are very effective in reducing edema. So in a light edema, absolutely, you can start with stockings.
If I may, I can, Joe Caprini, I really want to ask you to follow up on my question. So Giovanni, I'm even less lucky because I see patients with no edema and DVTs. And this is exactly what I want to ask Joe, because you divide. So if you see the patient, you know, say patient for the medical reasons in a hospital, laying down, and I'll tell you the sequence of events that we usually see. The first thing is happening is IPC is off when the DVT is diagnosed. The second thing is happening, the patient's on the heparin or other anticoagulation with no compression. So what is your recommendation, Joe? You were in the same setting, so that's why I'm asking you first.
Well, I've often had this happen many times, and the thing is that these patients, I'd like to put a short stretch compression on them and get them up and walk around, and get them out of bed as quickly as possible. And remember Hugo's work in this regard, and ambulating these patients is much safer than keeping them in bed. That's the first thing. The second thing is that the lawyers have promulgated this ridiculous concept that pneumatic compression is going to move clots out of the leg. And we know that getting patients out of the bed and walking produces a much greater hemodynamic effect than a pneumatic compression device. And Hugo and others have already proven that that does not, that walking is better than being in bed, and there's less stasis and so forth. And also the Bonamou rule, if they come in walking, then keep them walking. So that I don't agree with that, but we have a terrible time using that pneumatic compression. So I try to put on short stretch or put on a stocking. And I don't know exactly if I'm interpreting your question properly. Okay.
Okay, I don't know if there is any other point to touch.
Maybe we can just have a quick look at the questions and answers. That,
can I, if I'm audible now, if my connection is good, this is Molay Patel. Can I make some comments?
We can hear you very well.
Perfect.
Oh, perfect. You know, I had side discussions with Eberhard some time ago. And I told him that compliance is our problem because of open footwear and patients entering wet areas all the time. And the suggestion that he gave me, and Sigvaris has worked on it, is to produce or give me a leg component separately. And I think this is like the Velcro wraps. It is increasing compliance, and it is decreasing the tissue markings and the contact dermatitis for us. So I think that's very important because we can use these with cotton linings and so on. So that's my comment that I wanted to make at that time.
So you're suggesting, if I understood correctly, you're suggesting stockings without food?
Yeah. What's the opinion on this? Yes.
Yes, I can comment on that. You know, if you would live in India with open footwear and you have a normal classical compression stocking, after 2 weeks, your foot is worn through and you would have to buy a new stocking. So I think it's a much better concept in many of these situations to have a 2 pieces stocking, 1 piece of stocking for the lower leg only, and then a cheap low pressure device for the foot if needed. In most of the patients with non-severe edema and no edema of the foot, you might not even need a foot piece. But you know, even after vascular surgery, you know, from Italy, the study of Ricci, which you showed very well, that with the device, only with compression in the lower leg, without foot compression, he had a very good result without additional foot edema after vascular surgery. And that is something, at least for a 2 pieces stocking, as I said, you know, low budget, low pressure foot piece, and a good calf compression would fit for most of those patients. And as I said, as Molay said, if you're working in your fields and walking around, you might not even need the foot piece, but you need your compression in the calf. That is also a point which was put on earlier with the higher pressure, not in the ankle region, but in the calf region for a better pumping function of the calf. But of course, if you have lymphedema or things like that, you need more foot compression in those patients. But that is something we should think about for countries like India, where the classical stocking will be worn through after 1 or 2 weeks, and the patient will not be able to buy a new one because of the costs it would make.
Yeah, you know, Eberhard, I like, you know, I mean, to be politically correct, I call it economically challenged and climate challenged places. You know, so it's just that I think these sorts of places exist all over the world, you know, in all the tropical belt. And your suggestion, I guess it was a year ago that you made, and you know, we had a discussion about this, and this is probably a fantastic comment or a point.
If I may add a comment, first of all, Eberhard, I'm very happy that some of you are more confident with the so-called progressive compression. As you know, it was one of our publications, and we are very aware, so to say, that progressive compression sometimes is very effective. Regarding your point, I totally agree with you, especially if you have patient able to walk. Compression of the foot is not extremely important, so to say. I want to tell you my experience in the last year regarding Velcro wraps in patients with leg ulcers. I always recommend them to wear also something on the foot, because you know that very often the Velcro wraps are composed of 2 parts, a foot part and a leg part. And when they come to my office, I apply both of them. And when they come back, they have only the leg part, and they don't have any more the foot part. And they are perfectly fine. No foot edema, they are able to walk, they can wear the shoes, the normal shoes, and the ulcer is fine. The ulcer is going well. So maybe we need to review our concept on foot compression, at least in some patients, not in all patients, but at least in some patients, this can be done.
I agree with that wholeheartedly, and I've always enjoyed your work in that regard. And when in our Velcro wraps, you know, there's three kinds of things we do to the foot. We put a liner on which has no compression, and that serves well for a lot of patients. We have a low compression liner which has 15 millimeters of mercury in at the foot and ankle, and then of course the traditional foot piece. But in most cases we don't need to do that, and in many cases, and we've seen clinical evidence of the accuracy of your postulate, where reverse compression with higher compression in the calf is effective in reducing foot edema.
Thanks for your contribute. Any other comment? Fedor, do you have something to add?
Well, I think it's a fantastic panel. I just want to mention one aspect that is really fascinating to me is having this multinational panel shows that some issues really needs to be addressed regarding the compression. And I'm not talking about the climate, that was we were just talking about, but cultural issues, economical issues, tremendous difference between the countries and parts of the world that definitely affect outcomes. And then we really searching for the data, and we are having this as a major barrier, I think, and that's has not been yet addressed. And I think it's fascinating listening to all of you and realizing how much differences are around the world. So congratulations to Sigvaris for assembling such a panel. I think we should continue this discussion.
Great. Thanks a lot, Fedor. And thanks a lot also to Giovanni for the great moderation of this meeting, and a special thank also to the speakers for the fantastic presentations. We will definitely continue with this type of meetings and boards also, because this is really, as Fedor pointed out, this is an issue that we have huge differences global wide, and in regard to how to apply compression and how to treat patients correctly. So it makes sense to continue with this panel, and I'm looking forward for that. I can also just point out to the next MOH webinar that will take part in the last quarter of 2020. So we have not yet a date fixed, but we will communicate that as soon as possible, and also the topic for it. So thanks a lot to all of you.
Sylvain, thank you. Thank you for your great organization. And
thank you.
I could just would like to add one note. According to my wish at the beginning of the webinar, we at least learned that in cellulitis, compression is absolutely indicated, and this contraindication turned in a good indication. And even more amazing, we can use some form of compression in the very advanced stages of cardiac insufficiency. So less and less contraindications, and more indication.
Exactly. Great. Thanks a lot.
Bye.
Have a nice weekend. Bye. Thanks a lot.
You too. Bye.
Bye to all.
Was it